So today I will tell you about renal and ureteric trauma. First of all, you should know what are the causes of renal trauma. Of all the total type of trauma, the genitourinary tract are involved with 10%. Now the trauma involved to the genitourinary tract may be of two types, either the blunt trauma or trauma caused by penetrating injuries. Now, the more common, blunt trauma is more common, but the severity of injury is less here because only 5 to 10% of major injuries are there. These trauma are sustained in RTA, fall from height, assault, or different type of sports. Penetrating injuries are lesser, but in most of the cases they are of major type and they are caused by either sharp weapons or firearm injuries. Trauma may also be caused by iatrogenic types, and this is usually endo-urological procedure, ESWM, or person when some biopsy is taken from the kidney. So what are the clinical features? First of all, patient may feel pain abdomen, pain in that side which is involved. Patient will severe shock. There will be hematuria, which may be either visible hematuria or microscopic hematuria. But it is very significant that in 40% of cases there will be no hematuria, and especially if there is medical injury, then 24% cases there is no hematuria. The trauma to the renal system or renal and ureter, they are classified in different grades. They are grade 1. Grade 1 is where there is contusion of kidney. There is also perirenal hematoma, but they are non-enlarging and there is no laceration also. Grade 2, where the laceration is superficial, about 1 centimeter depth, not involving collecting system. It means there is no extravasation of urine. Also, hematoma may be there, that is perirenal, but it is non-expanding. Grade 3 are those trauma where laceration is more than 1 centimeter, but renal pelvis are not involved and collecting system is also not involved. So only in this side, the laceration is bigger than 1 centimeter, and no extravasation of urine is there because collecting system is not involved. Now grade 4 are those where lacerations involve the renal pelvis and collecting system also. So here is extravasation of urine in the perirenal region. There will be vascular injury involving the renal artery or vein. Segmental infarction will lead due to vascular injuries. And also there is subcapsular hematoma which is expanding. They are gradually expanding. Now grade 5 is the severest injury where the whole of the kidney is shattered. There is avulsion of renal hilum, either it is avulsed from the hilum or there is uretropelvic avulsion. There is complete laceration of renal artery or vein. Here in the picture you can see the different types, all grades, grade 1, grade 2. Here you see in the grade 2 there is less than 1 centimeter laceration, and in grade 3 it becomes bigger than 1 centimeter. In grade 4 you can see the involvement of vascular injury is there along with pericapsular hematoma, and in grade 5 whole of the kidney is shattered. There you can see there are multiple laceration, and whole of kidney is divided into different parts. Now what investigation is essential? So CECT, it is contrast enhanced CT scan of abdomen, is the investigation of choice. It accurately assesses the extent of renal and renal medical injuries and also shows non-renal injuries, that is the injuries that involve other part of the other viscera of the abdomen. Then where CECT is not available or it is not immediately available, in that case USG may show, but not that extent. Intravenous urogram may also give you indication somewhat, but CECT still is the investigation of choice if possible. Now, how do you manage the case of trauma? If this is a blunt trauma, most of the cases it will be managed conservatively. But if there is a history of penetrating injury, then you must need, it will need some sort of surgical intervention. Now coming to ureteric injury. Ureteric injury, because ureter is in such a place that it is not involved in blunt or penetrating injury usually, but it is mostly involved after some sort of operation or iatrogenic in nature, like hysterectomy, either vaginal or abdominal. In both cases, chances of ureteric injuries are there, and this can be avoided if pre-operatively ureteric extraction has been done, because in that case, ureter can be recognized. Injury recognized during surgery should be repaired immediately, if possible. Now, what will happen if there is a result of unilateral ureteric injury, that is one side? In many cause types, there will be no symptom, nothing will happen, and kidney will atrophy silently. Patient will have no difficulty. In other cases, if there is ureteric injury, it may result in hydronephrosis and pyenephrosis, loin pain, fever, and permanent loss of that kidney. In another cases, maybe fistula may develop through the wound of the operative wound, either vaginal or abdominal. Now, if there is bilateral ureteric ligation that leads to anuria, and here immediate intervention is required or patient will lose his life. So how can you repair a damaged ureter? Now there are different situations. First situation, there may be no loss of length of the ureter, there is no loss of tissue of ureter. In that case, spatulation and end-to-end anastomosis can be done very easily. But if there is loss is very little. In that case, mobilization of kidney or swath each of urinary bladder or Bory operation, these are the methods that can be done. But if there is marked loss of length of the ureter, in that case, transuretero-ureterostomy is to be done, or interposition of bowel loop, a small piece of bowel on its vessels is to be interposed, or even appendix. Nowadays the appendix is used for this purpose. And the last, that is if these are not possible, then you have to do a nephrectomy. Thank you.